So hi, my name's Hannah Jacob. I'm a general paediatric trainee in London with a special interest in safeguarding, and I'm absolutely delighted to be here with you today at the start of the child protection themed month of teaching. So this is a child protection themed month. We've also been teamed up with neonatology, which on the face of it might seem like a slightly strange pairing, but actually I would argue that child protection could have been paired with anything and actually you would have been able to find relevance. So I hope it's going to be a really, really good month. The idea of these lectures is basically to give you a bit of an update, to inspire you, and hopefully to provoke some discussion, because I think it's really important that we have a chance to think about some of the more nuanced areas of safeguarding, because lots of you will have had lots of safeguarding training already. And I guess the idea from my point of view with today is to think a little bit more real world and a little bit more naturally about the way in which we practice within safeguarding. Just to flag as well, there's a learning pack on the London School of Paediatric website, which should be up, if not already, then by this evening, which has got cases to work through, lots of information, and again, you can do that by yourself or with colleagues, so I'd really recommend that to you. So today, we're going to go through 3 cases. As I say, I've taken a slightly different stance on them from normal, just because I'm aware, you know, it's quite a broad range of trainees, so, you know, targeting ST1 to 8 is quite a challenge, and I didn't really want to tell you lots of things that you probably already know or can find out quite easily in other places. So I've gone for a slightly different take on some fairly familiar cases, and I would really, really appreciate your feedback, because it's the first time that I've done it in this way, so I would very much like to make it better and find out what works and what doesn't. And just to flag, obviously, that it's relevant to the progress curriculum for levels 1 to 3 and subspecialty trainees and general trainees. So I really hope that you all get something out of it. And please interrupt. I'm going to have to work out how I can see the chat. I'm going to try and get the chat up on my phone so I can see your answers to things. So let's please ask questions as we go along. Right, let's crack on. So case 1 is Jensen, who is an 8-month-old boy. Seen in paediatric emergency department, and mum says that she put him down for a nap. He was completely well beforehand. She put him down for a nap, and then he woke up from the nap and now he won't move his left leg. And you do an x-ray and he's got a femoral spiral fracture on that left side. So what now? You just I'd really encourage you all just to think about yourself, think, okay, it's the middle of the night. If I was in this situation, what am I actually going to do in this moment right now with this situation that presents itself? And if you can pop your answers in the chat, and I'm just going to quickly try and get up the chat on my phone. So Hannah. Let me escape so I can see what you're all saying in the chat. So it's definitely not going to work on my phone. Okay, so you've got an 8-month-old who has got a spiral fracture. What are you going to do? So someone said inform seniors. Absolutely, definitely, yes, agreed. Someone else has said, so we're going to need to body map him. Yes, so we're going to need to ask some more questions, have a proper look at him, document our findings on a body map, speak to the safeguarding team. Someone said full skeletal survey. Caroline wants a bit more information, find out about his development. Absolutely, yeah, all really, really good things. So we want more information. We want to examine him, and we're going to need to do some investigations. Okay. You know what I'm going to do, if everyone can bear it, I'm going to leave this on this mode so that I can keep bobbing back into the chat. Okay, good. So I'm going to focus on the imaging for a minute, because I think that this is one of the most interesting and quite controversial aspects of child safeguarding in terms of physical abuse. So this is the Royal College of Radiologists guideline from 2018. So it's called the Radiological Investigation of Suspected Physical Abuse in Children. And it's quite a weighty document. It was put together with the radiographers, and then it's been approved by the RCPCH. So paediatricians had sight of this and effectively signed off on it. And it basically goes into quite a lot of detail about exactly what investigations you need to do if you suspect physical abuse in a child. And I've just picked out the bit that is relevant to this specific question here, which is that imaging should always include a skeletal survey in children under 2 years and a skeletal survey and a CT head in children under 1 year. And so exactly as someone said in the chat, we're going to need to do some more investigations, and that is going to need to include a skeletal survey and a CT in this case. Okay, so just as a recap, a skeletal survey. So it's a defined set of plain radiographs. So this is X-rays. And again, the document goes into quite a lot of detail about exactly which bits of the body need to be seen in which X-ray and stuff. It's very detailed for the radiographers. And the idea is to identify occult fractures. So you know that this boy's got a femoral fracture, but actually the question is, does he have fractures elsewhere that may help you in forming an overall picture of this boy's level of risk? And that is risk both that this injury was caused as an inflicted injury, but also as part of his wider risk stratification in terms of how likely, if that were an inflicted injury, that this would be to happen again. And one of the key things is that it's repeated between 11 and 14 days. And actually, we're really quite bad at that because so much happens in the meantime that actually quite a number of these children don't end up being invited back within that window for their second set of X-rays. Okay, so in terms of the controversies, I think skeletal survey itself is pretty uncontroversial. Sometimes there's been some discussion about whether it's justified exposing a child to that degree of radiation, but actually even the full skeletal survey plus the CT head is only equivalent to, I think, 1 or 2 years living in Devon in terms of radiation exposure. And clearly the consequences of not doing that imaging in a child that is unable to communicate with you about the potential injury they may have suffered is really not worth thinking about. But there are some controversies, and I think that this document arose a number of concerns, particularly around skeletal survey. So one of the things that it says in that document is that you should take written consent for the skeletal survey. And I think that that's caused quite a lot of uncertainty and potentially has actually caused some problems for clinicians on the ground. And the logic is that it's an investigation and it's not directly related to the injury that they present with, and so it's important that you get written consent. And I certainly have been in a situation where the radiographers have said that they won't undertake the skeletal survey without the written consent on the basis that it says that that's what you're supposed to do in this document. And I think that's quite tricky because actually it may well be at odds with how we as clinicians feel about it. We haven't taken consent for the bloods that we take. We haven't taken consent, certainly haven't taken written consent rather for the bloods that you take. We haven't taken written consent in A&E probably for doing a top-to-toe examination and documenting that on a body map. And we aren't in the business of taking written consent for most investigations. So I think that is an area of controversy that I think will need to be ironed out in the second edition of this document. It's due for an update this year. But I think in reality, certainly from discussing with radiologists in this situation, that they feel very strongly that we should take written consent for a skeletal survey, and I'd be interested in your thoughts on that. One of the other controversies arising from this document was about whether every child under 2 in the household should have a skeletal survey. So the document is quite clear that siblings, if this was a multiple birth sibling, so let's say Jensen had a twin brother or sister, that you would do the same investigations radiologically for the twin as for the index case, so for Jensen in this case. And I think most of us would probably agree that actually the levels of exposure that you imagine that those two have had to whatever environment they've been in is probably so similar that that would seem reasonable. I think some people have felt slightly more uneasy about whether, let's say Jensen had a 20-month-old older brother. Would we definitely do a skeletal survey in the older brother? And I suspect that probably that's a little bit more grey by your level of concern about this injury and indeed what Jensen's skeletal survey itself showed. And then one of the other when I say controversy, perhaps challenges, as you may well all have experienced, is about what to do if there's a delay in getting the skeletal survey reported. So according to that document, you're supposed to have 2 independent radiologists report the skeletal survey, and they need to be confident enough in their own ability to look at those images to write a written report that ultimately has the potential to be going to court. And that's often, most district general hospitals may only have one person that feels confident to look at that skeletal survey and do prepare such a report. And so that can be quite challenging, that there's often a delay in getting the skeletal survey reported. And that can put you in a tricky position, because actually, until you know the outcome of that skeletal survey, and obviously depending on the other investigations, and again, your wider level of concern about this family, may make it quite tricky to make a decision about whether or not this child needs to stay in hospital awaiting the skeletal survey report. And if so, how long do you keep him? The other controversy that I wanted to bring up, because I think this is absolutely fascinating, and this is just one example of many, is a bit about accepted wisdom versus actual evidence. So I was certainly always taught at medical school, and to be honest, as a junior trainee, that a spiral fracture was always abusive, and unless there'd been, you know, a road traffic accident or some really high impact accident injury, that a spiral fracture in a child was abusive until proven otherwise. And basically that dogma is based on a study from 30 years ago by Dalton et al. And they looked retrospectively at 138 children under 3 who'd had femoral fractures, and found that in the group that were under 15 months, the spiral fracture was associated with abuse. And what they'd said in their paper was that the spiral fracture of the femur in a non-ambulatory child should raise the suspicion of abuse, although most abused children will present with non-spiral fractures. And actually, it seems to me that that's quite a measured summary of their findings. And yet somehow that's been translated, I think, in practice often into this absolute belief that a spiral fracture must always have been abusive, and people often have to work very hard in a situation where they really don't think that a spiral fracture was abusive, to convince people. And it's based on this, which is a relatively small study. So fast forward 25 years, Sabine Maguire and her colleagues in Cardiff did another retrospective cross-sectional series, and they looked at 95 children under 3 with femoral fractures and found no association between abuse and spiral fractures. And so I suppose my question to you, and I don't think there are any simple answers, is how do we overcome this concept? How do we overcome accepted wisdom? Because I think actually, and I think this is true of lots of things in medicine, we aren't necessarily very good at thinking hard. Well, I mean, lots of the time we don't even know what evidence it is, if any, that we're basing our practice on. And of course, that, you know, that's for lots of reasons, and often there isn't any evidence because the trial hasn't been done. But I think it's really interesting when you start scratching a bit below the surface that we are trained to get to, and we've kind of got ourselves into this situation that you've got problem A, that must mean that it's problem B, that the cause is B, and the solution must be C. And actually, I suppose I would encourage you to think a little bit more widely, and just to question why, you know, what evidence is a particular piece of hallowed information based on, and is it quite as robust as all that? So that might leave you feeling completely overwhelmed and thinking, oh God, okay, so everything I ever knew about physical abuse is completely wrong. And that isn't what I'm saying at all, but I'm saying that actually it's really interesting once you start looking for the evidence, that sometimes the evidence is not as strong as you might think. And of course, this is particularly relevant in child protection, because actually if you're talking about this suddenly going to court and you're in a position where someone's findings in the presentation are suddenly being picked apart by very experienced lawyers, actually it's really important and really useful for you to know exactly how confident you can be about making a particular statement based on the latest evidence. But don't worry. The Royal College of Paediatrics and Child Health Child Protection Evidence is an absolutely fantastic resource, and if you haven't seen this, I really recommend it wholeheartedly. So this is basically an evidence-based resource. It's a series of systematic reviews. So you'll remember from that pyramid of qualities of evidence that just above randomized control trials in the evidence, so right at the peak of quality of evidence, are systematic reviews and meta-analyses. And so basically this resource is a series of systematic reviews from a range of injuries and a range of different kinds of neglect in different age children. They look at all the available evidence, and they've got people whose job it is to work as systematic reviewers. So people who are expert at actually forming a question and then interrogating the published literature about it. And they essentially pull all those relevant studies together, extract where they can, extract the data where they can, and if it's possible to extract enough numbers to do a meta-analysis and actually combine the figures to give you a hard figure, they will. And they update them regularly. So so when you look at them, you can see when a particular review was last looked at, and it's completely free. So the one I think that's most widely used is the bruising one. So if you were going to start and just out of interest have a look at one of them, I'd recommend the bruising one, because it's fantastic, and they did have enough numbers to do a meta-analysis, and so they've included figures from the published evidence about how likely a bruise in a particular place on the child's body is to be as a result of inflicted injury, which obviously, if you think about report writing, for example, is absolutely fantastic. Okay, so what have we said about case one? Remember the siblings. So I think you all know in terms of the siblings and thinking about where they are in that moment when they're in A&E, and you ask about the siblings and ask who's looking after them and check that they're not at home by themselves or with a parent that you might have worries about. But actually, it's really important that we don't forget about siblings, particularly young siblings, in terms of whether they may well also need imaging. I've explained that the Royal College of Radiology guidelines is really useful for working out exactly what imaging needs to be done in which situations, and particularly thinking about different age children. And then the Royal College of Paediatrics and Child Health, Child Protection Evidence is this fantastic free resource that synthesises the evidence and brings it all together for you. So I really wholeheartedly recommend that to you. Okay, let me just have a quick look at any of the questions so that I'm... Okay, so no one's put anything in the chat, fine. So just chuck questions in there if you've got other questions, and otherwise we'll crack on with case two then. Okay, so case two. This is Rahima, a 6-year-old girl who was due to see you in asthma clinic in paediatric outpatients. And she's not been brought to the appointment. And this is the second time in a row, so this is the second appointment in the last 3 months that she's missed. And you have a look on the computer and you see that in the last 6 months, she's come to the emergency department 3 times with wheeze, and once she's had to be admitted and she's actually had to have IV bronchodilators. So what do? Let's say it's a morning clinic. I'm being kind here. It's a morning clinic and she happens to be the last person on your list. So you've got no one else to see. And that's what you've been told about this girl. So she was supposed to come to see you today. It's the second time she hasn't come. And you know she's been to A&E 3 times in the last 6 months with wheeze. So what are you going to do? What's your thought process? What are you worried about? And what are you going to do about it? I'll just give you a couple of minutes. If you pop bits in the chat.
Hannah, can you hear me? It's Najette. Hannah? Hannah?
Okay, so someone said that they'll call the parents. Absolutely, yes. Very good point, because sometimes at that point you discover that actually they hadn't got the letter, or they didn't realise, or they'd forgotten that it was today. It was actually supposed to be tomorrow. Sarah said call the family, find out the barriers for coming to clinic. Yeah, it needs a non-judgmental conversation so family can explain. Absolutely. It may be that they've just had an absolute nightmare of a day and the car broke down and the bus was late and whatever else. Yeah, so someone said, is there a reason why she hasn't attended? Busy home life, other children. Is the child taking her preventers? Yes, excellent point. So this girl does have a brown inhaler. Anyone got any ideas about how you can actually check whether she's taking her preventer? Yeah, Sarah's saying, are they chargeable patients? Yeah, so that's a reference to perhaps this family aren't coming to outpatients because they're worried that they're going to be charged for using NHS care. Yeah, so someone said check their prescriptions. Yeah. So the GP is going to be a really important source here, aren't they? Yeah. Caroline said, yeah, speak to social care, find out if she's already known to them, child in need, are there child protection issues already? So we're saying absolutely want to speak to the family and get a little bit more information, try and understand a little bit more about why they might not have come. speak to social care to see if they know any more, speak to the GP. Anyone got any other ideas about anyone else we could talk to try and get a little bit more background? Yeah, that it's possible that your specialist nurse may have been in contact with the family. And yes, someone said about the other people who've looked after her during her admissions. Yeah, a couple of people have said school. Fantastic. Yeah, good. Absolutely. So I think the key thing is that you want to triangulate your views, because that's all going to be really, really important. Fantastic. Okay, so yeah, you've said all this. So speak to the parents. The number of times that I've thought there was something terrible going on because a child hadn't been brought, and then actually we had the wrong address on the system, or it turns out that the letter didn't go, or the letter said a different time from what was on the computer screen. Yeah, find out whether there's a communication barrier. So I remember one time, and the letter had gone out, but the font of the letter had been too small, and the mum was visually impaired, and I think the daughter was quite little, so she wasn't able to read. You know, really, really simple things. Is there a language issue? Sarah's already mentioned actually about whether there are anxieties for them about coming to an outpatient appointment because they may be concerned about accessing NHS services. We've already talked about the GP, and that's a really important source of finding out about whether the prescriptions have been cashed. But also, I think GPs are a fantastic resource for getting a bit more context about the family. You know, what do they know about the other siblings? What do they know about the parents? Are there other health issues for this family? Are there wider issues? Someone mentioned school. So what's her attendance like? Because I would argue that probably your level of concern about this child is going to be quite different if I say to you that schools say she's there every day, she's immaculately presented, they've got no concerns, the family are really engaged, they're not worried, compared to if I tell you that you phone school and they say her attendance is 70 to 80%. She's spending a lot of time eating food at the snack table. You know, she's wearing a uniform that's too small. She's got 3 or 4 siblings and they're all in the same situation. Mum seems really stressed. They've not met dad. You know, it's just really important to get contextual information. And we've already said that social care, it would be interesting to check in with social care and work out whether they know this family and whether there's anything else that they would like to do. So this is directly from the College Child Protection Companion about medical neglect. And I've put this in because actually I think that this is perhaps a broader definition than most of us would routinely think of. So parents and carers may minimise or deny a child's illness or health needs, fail to seek appropriate medical care, either acutely or for a long-term condition, fail to administer medication or treatment, and that it includes all aspects of healthcare, including dental care. And we've all seen situations where actually the main source of medical neglect that you've seen is that the child has not been taken to the dentist or had their teeth brushed on a regular basis, with resulting caries and terrible dentition. And I think the key thing from that definition is that the child's health and well-being is compromised, because actually sometimes there may be, and I think this is why it's so useful to talk to families, there may well be issues related to their access to care that you can help them to address. But actually the key thing, and I think we've got to remember that we're paediatricians first and foremost, and what we're trying to do is prevent the compromise of this child's health and well-being, and the onus is on us to try and optimize and mitigate the risks of why this family, mitigate the reasons why this family may well not be seeking care, and present it to them in the best way that we can. So this is from Lord Laming's reflections on his involvement in the Victoria Columbia case, and he talks about how there are 4 key components of child protection for health professionals, and in fact he was meaning more broadly for social care as well. So the first one is observation. So a professional curiosity. I think it's all too easy, and I think the computer systems are set up, or if you've still got those pieces of paper where you have to tick, whether you want them to have another appointment, actually stopping and thinking, hang on a minute, why hasn't this child been brought to clinic? Actually, they weren't brought last time. Is there something else going on here? And forcing yourself, if it's not something that comes naturally to you, to really think, actually, do I need to be doing, is there more to this than meets the eye? So observation is the first thing. Communication, we've said already that we want to speak to school, we want to speak to the health visitor, we want to speak to the GP, and actually we probably want to speak to social care potentially. And I think sharing your concerns and communicating them appropriately with appropriate colleagues is really important. Then you have to bring that all together. And I think this is where often the referral to social care is really important, because actually you need to assimilate that information. You know from the serious case reviews that when things have gone horribly wrong, but almost always lots of different people in lots of different places had niggles, but for some reason it wasn't all brought together in one place where that information was all kind of analysed together to build up an overall picture. And then you have to make an action plan. So we need to be able to mitigate the risk of harm to this child. So depending on the information that you get from your triangulation of views, it may well be appropriate in this situation to do a social care referral. Now, I'm not saying that every child that is not brought to clinic appointments must immediately be referred to social care at all. But I think what you've got to do, and I don't expect people to do this unilaterally, I think you need to speak to your senior colleagues and involve the child protection team, have a low threshold for involving your trust child protection team. But I think particularly if on your you discover other areas in which there's something about this that is not sitting comfortably with you, I think it's actually really important that you make that social care referral. And what will basically happen at that point is almost certainly there would be a professionals meeting. And what you really want is you want representatives from health, by which I mean you seeing them in clinic, but also the GP and the health visitor. Education, so ideally, their class teacher or someone senior from the school, and then representatives from social care. And there may be other professionals involved depending on the family's circumstances. And that's really helpful because essentially what you're doing is you're all identifying potential aspects of neglect. We've talked about the ways in which that might present, say, at school. The GP may have other insights. And people in that room may well know of other issues within the family. So it may be actually perhaps that there's a component of domestic abuse, or that perhaps one of the parents' mental health has not been addressed properly. And it will allow you, between you, to identify areas for further investigation. And who does that is going to depend on what the situation is and what the concerns are. And then the key thing is that you can make a plan for support. And the family, it's really important that the family are kept updated about that. So I think one of the controversies that arises from a case like this is the whole concept of not being brought. So I think it's really important. It sounds really simple, but I think, again, the computer systems and those forms that you have on the front of your clinic letters make it all too easy to talk about did not attend. And actually, even just the phrase was not brought compared to did not attend just completely shifts the emphasis and the kind of blame, for want of a better word, from the child or young person onto their carer. And I think that that's completely right. Now, we've talked about some situations where it may be that it was completely beyond the carer's, that the carer was not able to bring that child and that there are other issues going on for them. But I think that just moving from the simple phraseology to was not brought, I think is a really important first step in shifting the emphasis here. Where you can, and I know some trusts are really reluctant not to do this, but avoiding the automatic 2 strikes and you're out situation. So some trusts will have a thing that if you don't attend 2 appointments, or you're not brought to 2 appointments in a row, they just don't offer you another appointment unless someone actively pursues it, as we're discussing here. I think one of the controversies and challenges is about quite where your responsibility is in terms of follow-up and the extent to which you chase, because you can totally imagine a situation where actually this is a Friday afternoon clinic and you phone the family and you can't get through and you've no idea whether the number's wrong on the system or the parents don't pick up to an unidentified number, or actually mum's trying to deal with 4 children that are all running around the house all at the same time and doesn't hear her phone. You might phone the GP and they don't phone you back, and the duty doctor isn't, is busy doing something else, or you speak to the school and you're not getting much information from them. And it can be hard to know how much to get the bit between your teeth about it. And I suppose it comes back to, 2 things, I think. First of all, what Lord Laming said about your observations. So you will have a sense based on the information that you are able to gather about your level of worry about that family. And I would urge you to trust that sense. And the other thing is that I don't think that these situations and these judgments are to be made unilaterally. So I would say make good use of your colleagues. You will have you'll have a consultant supervising this clinic. If they're not there, there'll be an on-call consultant. You've got your child protection team. You've got your specialist nurses. So make use of the other people around you, because I don't think it would ever be a situation where it was on your head, even as a consultant, to make a solo decision about whether or not to pursue this without the opportunity to triangulate views with your colleagues. And I think, and we've talked a little bit about this, that the key thing is about optimizing engagement. So it's very easy to say, oh, well, Dad knew when the appointment was and he just didn't come and he's just not organised and he's just not prioritising his child's health. But actually, families have got a lot going on, and actually it's pretty, and in some ways, the model of getting them to miss school, miss work, all the rest of it to come and see you in your clinic, in your hospital, may actually not be the right way. And I think we need to think hard as a team about how we can optimize engagement. So actually, is this a family that might really like having a virtual appointment if their spoken English is okay and if their access to technology is good enough? Actually, is this someone who the specialist nurse might be able to go and visit at home? Or maybe you could go with the specialist nurse to do a school appointment. And thinking, the onus in some ways is on us, I think, to try and optimize engagement. And again, not us in isolation. Education can help, social care can help, the GP can help, but shifting it like that as well avoids just constantly pinning it on families, which I think particularly in families where there's lots going on is really important. So the other controversy, and perhaps Rahima is not the most controversial example of this, it is about what constitutes neglect for social care referrals. People talk about that dreaded phrase, or will it meet threshold with social care? And actually, I don't really like that phrase, but I think it's an interesting exercise for us to think to ourselves, okay, so Rahima in this situation was 6. Would it be different if she hadn't come to her appointment and she was 15? Or some people would say, okay, so perhaps the emphasis is a little bit more on her taking responsibility for her own health compared to her parents, maybe. But actually, the fact remains that you've got a 15-year-old who's had multiple wheeze presentations to A&E and doesn't seem to be engaging with the management of her long-term condition. So I don't think that necessarily would make a difference to me, but it somehow does feel different in some ways. And that's, I think, important that we're honest about that. What about if actually the medical problem was obesity? At what point does having an obese child become medical neglect? And again, these are discussions that are ongoing. They are controversial issues and they're not easy to talk about. And I think, as with so much in safeguarding, some people just can't face the grey, and I do understand that. But I think it's important that we force ourselves to not ignore these situations. And again, I said we're not expecting people to sort this out by themselves, but just to get the conversation going. Because actually, no, I don't think that every parent of an obese child has medically neglected them, but there may well be situations where actually a child's health problem of obesity has not been adequately that perhaps parents haven't engaged adequately with health services in an attempt to deal with that as a medical problem. And maybe at some point that does become a component of medical neglect. And I've put this again just to be controversial because I love throwing a grenade into something. What about declining routine vaccinations? Is that medical neglect? Probably lots of people would say, no, it's not technically. I suppose it's your right as a parent if you've got your own personal reasons for not getting your child vaccinated. But what about if that child has sickle cell disease and actually suddenly we know how much more important those pneumococcal vaccines are? So I think these are questions, and I don't expect necessarily for there to be lots of answers, because I think it is really hard. But I think it's interesting for us to start to think about these issues. I'd be interested to see your thoughts. I don't know if anyone's put anything in the chat. I'm sorry to keep having to go back and forth into the chat. Let's see what anyone's put. Does anyone have any major thoughts about medical neglect, or what constitutes medical neglect or not? I'll tell you what, because it's already 20 to 2. Pop your thoughts in the chat if you've got any insights. I would be interested to know what you think, because I think this is a tricky area. Okay, so we've said in this sort of medical neglect scenario that collateral history is really valuable, and particularly when a child is repeatedly not brought. We've talked about the GP as a really important source of information, school, potentially the health visitor in a younger child, because they'll often have done home visits. That a professionals meeting should be viewed as a positive step, and families won't always take it as that, but actually having all those people in the room together to share information and then make a plan around supporting this family to engage more actually is a really positive step. And we've talked a bit about how there is an element of professional judgment in what constitutes medical neglect. And I think the key thing, which I've said again and again, and I will keep saying, is about how important it is to speak to colleagues, because I think these aren't easy decisions. And I think it's always better to have a range of thoughts from people if there's any kind of question about what you do in a situation. Okay, so this is the third case, Poppy. And again, I think this scenario, or some variation in this scenario, may well be familiar to you, particularly the more senior trainees among you. So this is an 18-month-old girl brought to A&E by her mum, having been referred by the GP. So mum took Poppy to the GP this morning and said that she was having these gagging episodes at home, lasting 10 to 20 seconds, in which her eyes were rolling back. In terms of the past medical history, this is from the GP letter, and you don't have any more notes on your system. So Poppy's got a gastrostomy for slow weight gain, and she has overnight continuous feeds. She's got multiple food intolerances. She's had some allergy testing, and they've not identified any allergens. So the most recent allergy letter, which you do have on your system, saw one of your colleagues, said that there's no restrictions on what she's able to eat orally. And she's also had some problems with leg weakness. And she saw a neurology colleague at a different hospital, and they were happy that her examination was normal. She'd had some muscle and nerve studies, and they were all normal, so they discharged her. So what now? So you're in A&E, mum's there, she's telling you about these episodes. The GP understandably was worried and sent her in, and you've got this story. What do you do? I'll go back to the chat. Okay, so someone's concerned about non-accidental injury. Yep, someone said Munchausen's by proxy, so fabricated induced illness. We want a good history, definitely. We want some videos. Yep. Caroline's worried, treat any acute issue, but possibly fabricated induced illness. Yeah, absolutely. Okay, so people are worried about possible fabricated induced illness, and the general sense is that we probably need to get a decent history, admit, observe. Yeah, and I think, a few people have made this point. We don't know very much at this point, but actually it's important that we have fabricated induced illness on our differential and that we're treating acute problems. And someone said it's tricky to get the balance between admitting to observe and asking, reinforcing the behaviour of medicalising things. So that's a really interesting point that Kavita's made, and I think we're going to come back to that a little bit more about the extent to which you potentially perpetuate these things. Someone said speak to the other parent. Yeah, so again, collateral history is really important. Okay, so let's find out where this goes. So you see Poppy, and as someone said, we're obviously going to do all the sensible acute things, and you decide to admit her because it's not very clear and you need some time. Okay, so she's admitted for observation. She doesn't have any more of these gagging episodes. And mum runs the gastrostomy feeds day and night and doesn't feed her while she's on the ward because she says she's not well and she doesn't want her to eat anything orally. Poppy's kept in the cot or strapped in the buggy because mum says her legs are weak and she's just not safe to walk around. And mum also mentions to one of your colleagues that actually Poppy had a place in nursery, but mum didn't want to send her because she doesn't feel that they can meet her needs. Now your consultant comes along and manages to persuade mum to come to the seminar room to have a conversation away from the bedside, just with the consultant and one of your colleagues and one of your junior colleagues and mum. And while Poppy is looked after by the nurses, she manages to eat her whole lunch orally, and she's running around the ward happily with no sign of any leg weakness. So, as many of you have identified, this is a situation that has the potential to be fabricated and induced illness. So what are some of the clues that you might look for in a situation like this? So are the signs and symptoms not explained by a known medical condition? And again, that's not to say that we know everything, and that's not to say that at the front door it's always going to be immediately apparent that this is what the situation is. But as someone said earlier, having this on your differential earlier is actually a really important part of starting this family on a therapeutic pathway, if that is what this turns out to be. There are physical examination or investigations that do not explain the presentation. An inexplicably poor response to treatment. So it seems like there's problem X, you diagnose problem Y and you give the appropriate treatment, and it doesn't seem to improve things. Acute symptoms observed exclusively by a carer. And again, there are some things that, might only happen when you go to sleep, or happen to only happen, at home, and then you admit them and then nothing happens for 24 hours. And we're not saying that any of these things in isolation absolutely mean that it must be fabricated induced illness, but it just begins to plant the seed in your mind. One thing that can be quite common in these situations is that as soon as one problem is resolved, or tests show that's been disregarded as something of great concern from a medical point of view, a new symptom develops. And one of the key things, and I think for me this is one of the red flags just with that first page, is the involvement of many health professionals. So she had a gastrostomy with gastroenterologists at one hospital. She'd seen a neurologist at another hospital. She'd seen the allergy doctor at your hospital. She'd obviously seen the GP. Then she was seeing you. And very often in this situation, you don't have access to the letters from all those other professionals. And so quite often it does end up being the parents that are telling you what other professionals have said and what their plan has been and what the investigations have shown, which might be fine. And let's face it, in these complex children, you often are really relying on the parents as major sources of fantastic information, particularly between hospitals. But it adds a layer of complexity. And the key thing about FII is that it limits the child's daily life beyond what is expected based on whatever the problem is. And that's really where the harm ensues. So this is a child who's not been allowed to eat orally, even though actually the prevailing view was that she could. She's not been allowed to walk or run around, even though, again, actually there doesn't seem to be a reason why she can't. She's not been allowed to go to nursery because mum feels that they're not going to be able to meet her needs. And this is all very restrictive and limiting of her life, and of course increasing her reliance on mum. Okay, so there are lots of challenges with fabricated and induced illness. I think one of the big ones is that there may be some underlying pathology, but the key thing is that it's often exaggerated by the carer. That the carer may seem completely plausible in what they say and very caring and loving and very involved and knowledgeable about what's going on. And that as clinicians, we are worried about missing something rare. What if this is a child who happens to have that syndrome that you maybe learnt about for 5 minutes when you were doing your exams, that happens to involve gagging and difficulty gaining weight and some intermittent leg weakness and some allergies? People worry about their colleagues not agreeing with them. So actually, particularly as a generalist, it can be quite difficult to say to the neurologists or the gastroenterologists or the respiratory physicians or whoever, I'm not picking on those particularly, it's just in this case they were the ones that were involved, who might say, oh, but it could be this extremely rare thing and we need to do lots more investigations. And also the bottom line is that we all want to be liked, and actually there is an anxiety about this mum and parents like this complaining if actually you get to a point where you're saying, well, actually, we don't think we do need to do any more investigations because we think that we need to move towards rehabilitation. So what do you actually do? Well, you guys are well ahead of the game. So I think the key thing, to be honest, in the first instance is to have fabricated and induced illness in your differential diagnosis of a perplexing presentation. And I think actually perplexing presentations, I mean, there are technical definitions, but I think most of you probably know what I mean when I say that, in that it's a story that doesn't quite hang together. And we all know of situations where the story didn't hang together and then something clinched it and actually it turned out to be syndrome X or, problem Y. But I think if something is perplexing and it doesn't all hang together, just have that thought in your mind. You mentioned already about collateral history, so an older child certainly speaking to them alone. And even in this situation where you weren't speaking to Poppy, actually the observations made when she was by herself were a really important part of forming information about this situation. Other carers, so someone mentioned speaking to the other parents. School can be really useful. Again, a child who comes to school in a wheelchair but then seems somehow able to get out of the wheelchair and do PE completely fine, and then at the end of the day gets back in the wheelchair to be picked up by the parent is quite a telling situation. And the GP again, because again, they're going to know about the family. Speaking to colleagues, again, I know I sound like a broken record about this, but I think this is something where your trust child protection team are going to want to be involved and to be involved early, because these ones are complicated. One of the interesting things is about observing the carer's response to your reassurance about a symptom or a presentation, and about changes in management. So we're moving from investigation to a kind of rehabilitation. Because one of the things that can be really difficult is that it's completely normal to be anxious about your child if they're unwell. And actually, the key thing is most parents, even people who are, really quite worried about their children, when you take a decent history, do a proper examination, do the necessary tests, and then say, actually, we're really reassured, and now we're going to move to managing the headaches or managing the tummy ache or managing the leg weakness. Actually, most of the time, most parents will come along with you on that journey. And actually, if they don't, again, you need to start thinking, is there something else going on here? And the other thing, and I think this is probably the hardest of all of the things I've said, is to keep the child and not the carer at the centre of your management. Because when you've been in these situations, you do find yourself expending a huge amount of energy and time talking to, looking at, thinking about the parent. And all that time, your gaze is diverted from the child, who, of course, should be at the centre of your management. And it's really hard. And it's a part of what the parents are doing, consciously or otherwise, is drawing you to them and away from the child. And that can be really hard. So one of the controversies about fabricated induced illness is that a huge amount of the harm is caused by us. And that may sound controversial, but someone had already said, actually, does admitting this child perpetuate the idea that this is there's lots medically going on here? I think it's tricky, and I think if you aren't sure, and it's observation and admission will always buy you time to triangulate views. So, but I think that's a really important point about how much we perpetuate the worry here. But there is a danger that you get into doing more investigations, and you do an MRI, you do a CT, and then you think, oh, there's some things that a CT misses. So you do an MRI, and then actually, well, maybe it's a vascular thing. So then you do an MRA, and it's just more and more and more. You're not 100% sure, so you go and you refer them to subspecialist X, Y, and Z, and suddenly this child who's 18 months old has got 6 volumes of notes, and is seen at 4 different hospitals by 7 different specialists, and none of the letters get to each other. And again, that puts the parent in a very strong position and puts you on the back foot in terms of working out exactly what's going on. So one of the ways of helping to avoid that is to have one coordinating clinician. So general paediatricians or community paediatricians are often well placed to do that. And I've written, this might sound a bit controversial, but they are going to need to stay very strong in the face of the super duper subspecialists, because again, if you go and see expert Y, there probably was a case history one time of a child that had this enormously complex array of symptoms, and perhaps this child has got that, and we just need to do 45 million more investigations to find out why. Well, at some point you're going to have to call it and say, it's actually far more likely that this just is an exaggeration of symptoms, and actually for the child, who is ultimately what we're all aiming to the person we're all aiming to look after, we need to actually call time on this and say, no, we want to focus on rehabilitation, on getting you better. And again, the other controversy, a bit like the medical neglect one, is about the threshold for social care involvement. So at what point does this situation warrant a social care referral? And probably even more so than in your medical neglect situation, that this is going to go down really, really badly with this family, almost certainly. So one of the things that Daniel Glaser says in her paper that I've put the reference for there is about reframing it so that actually you make your referral based on, at the moment, this child's functioning is impaired, and what we want to do as part, with this referral, because it says on the social care referral, what are you hoping to achieve with this referral? Well, actually, you're aiming to restore that child's life to as normal as possible. And actually, that might well be about additional support for the family. But also the involvement of social care potentially holds the professionals to account in terms of education, in terms of health, and hopefully it allows you to have a kind of coordinated and fairly consistent approach. So the key points in this case, I think, and you've all said this, but I think considering fabricated and induced illness in any presentation is perplexing. I'm not saying it has to be your number one diagnosis. I'm not saying it has to be your only diagnosis, but I think it's important that it be on the list. Discussion early with experienced colleagues is always going to be important. And I think these cases are really, really hard. And wherever possible, you want to be discussing them in big open forums with your colleagues because I think people are going to have a difference of views. And if you are going to refer to social care, the key thing is to frame your referral in terms of reversing the current impairment in the child's function, because actually that is really what you're aiming at doing. Okay, so in summary, safeguarding, as if you didn't know it, is full of controversy and grey areas. I hope that I've been able to show you that safeguarding is also, because of all that, really interesting and exciting and different and varied, and that there's a whole range of professionals involved with an increasing body of evidence, and that this is a really growing area. So please get in touch if you are interested in safeguarding and you'd like to know more about how you can be involved. I think I've said this over and over again, but talking to colleagues early, especially if you've got a niggle, and even if you can't quite put your finger on it, tell someone else, because two brains are always better than one. And also just to say, by way of reassurance as well, that there are loads of fantastic resources out there to help you. So I've talked already about the college systematic reviews, child protection evidence. There's also the Child Protection Companion, which is now available on the college website with your login. But there's also some, don't forget the Bubbles resources around safeguarding, and some FOAMED stuff that is also really useful. So thank you very much. That's my email address and my Twitter handle. This is the QR code for the feedback. And I think Najet's already put it into the chat. But if anyone's got any questions, I'm very happy to answer those. Let me get you back up. And I can stop sharing. We can hopefully see each other. Right, let me see what other people have written. Oh yeah, okay, so Najet's put the feedback form in there. I'd be really grateful for your feedback, because like I say, I've taken a slightly different stance from normal, and I'd be interested to know how that's been received by people, and if you've got any suggestions for making it better. And Najet said that the learning pack should be up today or tomorrow. And Najet said, yeah, thank you all for doing the feedback, that she's got some technical problem, so she can't hear you. So, LL, regarding first case, what's the rationale behind the second imaging at 12 to 14 days, and what may be shown? Oh, sorry, I should have said this. Okay, so in theory, if that femoral fracture was the result of inflicted injury, it is possible that he may have another fracture elsewhere on the body that, for whatever reason, doesn't show up. Perhaps it's just a hairline fracture or something that wouldn't necessarily show up at that initial skeletal survey. But if you re-imaged 10 or 14 or 11 to 14 days later, you may well then see callus formation. So you literally do the same set of images again. And because, of course, you've got that baseline from almost 2 weeks before, you can then very easily say, actually, you know what, now there is a little ridge in at the wrist that there wasn't when we last did this. And actually, I'm concerned that may be the site of another fracture. Good question. Oh, and Najet said again, sorry, that the next safeguarding lecture is Thursday, the 21st of January at 1 p.m. So the whole timetable is on the LSP website, so that there are a couple of other really exciting safeguarding lectures that will definitely be worth joining for. Ash, exam MCQs highlight a close relationship between maternal mental health issues and FII. How frequently is this being the case in reality? Yeah, great question, Ash. So I was very conscious as I was saying that about the spiral fractures, thinking, oh God, this is terrible, because it's going to really confuse everyone for multiple choice questions that, of course, are sometimes based on wisdom rather than the evidence. So there is an association. And they did a big BPSU study. So the British Paediatric Surveillance Unit did a big study about fabricated and induced illness more than 20 years ago. So it's quite out of date. But they certainly found that relationship. And it's felt to be, so it is mostly mothers who seem to be perpetuating the fabrication. It is often associated with particular personality disorders, and that's both on self-report and on psychiatrist assessment. I think particularly borderline personality disorder. But as with all of these things, there are plenty of people with borderline personality disorder who look after their children fantastically and don't have any of those traits. So I wouldn't want to make a kind of generalization. But there does tend to be an association. The other thing with fabricated and induced illness is that there is often a family history of other slightly perplexing presentations. So again, these will often be, because it is mostly the mother, these will often be mothers who again themselves may see a range of specialists for a range of problems and have a range of diagnoses for which, you know, that people may or may not have been massively convinced by at the time. So the kind of classic, I mean, almost cliched example is, you know, mum who says that she can't walk and is in a wheelchair, but no one's ever really been able to find out why, or get to the bottom of exactly the source of why she can't walk. So that's and then the child presents with a kind of fabrication. And again, I'm wary about making these generalizations because there are huge numbers of parents in that situation who you know, aren't involved in fabricated induced illness. And similarly, sometimes in fabricated induced illness, there's no history or no known history of familial mental health or any problems previously. But there is certainly a recurrence within families of perplexing presentations. Does anyone have any other questions? Thank you all for coming. If you're happy to fill in the feedback, that would be amazing. I'd be very grateful. And yeah, any suggestions about how to change things or things you'd like to see included or not, I'd be very grateful to hear. Thank you very much, guys.